For the next highly anticipated session, Meet the Professor table, it is my honor to introduce our very own scientific chairman of this wonderful meeting, Professor Ratha-korn Vilaichone. He needs no introduction. He's going to be our first moderator in this session.
And for another moderator, Professor Andrew Chan is a gastroenterologist, the Daniel K. Podolsky, Professor of Medicine at Harvard Medical School, Professor of Immunology and Infectious Disease at Harvard T.H. Chan School of Public Health, Chief of the Clinical and Translation Epidemiology Unit at Massachusetts General Hospital, and Director of Epidemiology at the MGH Cancer Center. Please warmly welcome Professor Ratha-korn and Professor Andrew Chan on the stage.
Thank you so much for kind introductions. I think it's very great honors for us to have three leaders of the GIs, the endoscopies, GI cancers, and for the peptic ulcers around the Asia Pacific regions to be in our professor table for today. And very first, before we're going to start, like Andy to give introductions to our first professor, please.
Yes, so our first speaker today will be Professor Muhammad Miftahussurur from Indonesia. He is a gastrohepatologist in the Department of Internal Medicine and the Faculty of Medicine at Universitas Airlangga. And he's a world's expert in Helicobacter pylori, among other terrific scientific contributions. Today he will be speaking about colorectal cancer in young adults, what is really going on.
Thank you. Good morning. I would like thanks to Professor Frajamachai and also Professor Ratha-korn to having me in here, and also Professor Andrew that become the moderator in this session. We want to talk about the important and also concerning trend in oncology, the rising incidence of the colorectal cancer among young adults. So in this presentation, we talk about what is the colorectal cancer actually is. So in the colorectal cancer or CRC is the type cancer that starts a small growth called a polyp in the inner lining of the large intestine, including colon and also rectum. And when we look the global situation, colorectal cancer is the third most commonly of the diagnosed cancer worldwide. So early detection is crucial. And colorectal cancer recently is the major global health problem. In 2020, nearly 2 million new cases and over 900,000 deaths worldwide. And in Asia, contributed to about half of the global cases, and notably around 10% occur in younger individuals, showing a worrying rise of the colorectal case among the young people. And the image shows that the estimated number of the colorectal cancer deaths in the 2020 and projected deaths in 2040, indicating a significant increase across all of the world, with largest rise expected in China. How about Indonesia? During 2008 until 2012 showed that the colorectal cancer was higher in men rather than women, and colorectal cancer in age less than 50 years old in 14.9%. CRC incidence and mortality have decreased among older adults, but unfortunately are increasing in the individuals under 50 years old. In the US, incidence among 20 until 49 years old rose for 8.6 to 12.9 per 100,000 between 92 until 2018, with the greatest rise in age 40 until 49 years old. So therefore, in the figure shows about average annual percentage changes in CRC incidence between younger adults, 25 until 49 years old, and also older adults, 50 until 70 years old, across different countries. And the fact is, CRC incidence in increasing in younger adults, but declining or stabilizing in older adults. And since 1994, CRC incidence in individual younger than 50 has been increasing by 2% until per years. So what is the risk? Some risk factor that contribute the development of young onset colorectal cancer. This factor occur throughout the person's life, such as environmental exposures and also medication use and dietary habits. All this can affect the gut microbes or the balance of the bacteria in our intestine. When this balance is disturbed, it can lead to inflammations, weakening the immunity, and also conditions that promote the tumor growth. Early onset of the colorectal cancer have the significant proportion with Lynch syndrome, and then this is being the most common genetic cause. And germline mutations in additional high and the moderate penetration the cancer genes has also been associated with the increased risk of colorectal neoplasia. Approximately 1 in 5 individuals that diagnosed with colorectal cancer at age younger than 50 years carries a germline mutations associated with cancer. The figure presented that pathogenic germline mutation in genes known to be associated with the cancer predisposition were identified in 79 with the variant of uncertain significance identified in the additional 21 or 6.7% individuals on the multigens panels. So, interestingly, the high consumption of the processed meat, greater consumption of the sugar, higher Western dietary, and each serving day of the sugar sweetened beverage intake during adolescence is significantly associated with the increase of early onset of colorectal cancer. Also, alcohol consumption in the significant to increase for early onset, and chronic alcohol consumption may promote colorectal cancer by causing intestinal dysbiosis, which disrupt the gut bacteria balance and also increase intestinal permeability and inflammation and leads to the production of carcinogenic acetaldehyde. So when we measure that, it is very interesting that excessive TV watching, more than 14 hours per week, is associated with 1.69-fold higher risk for early onset. And I believe when we watching TV, we added the more sugar or some the diet additional. And sedentary lifestyle increase the risk of the early onset by disrupting the gut microbiota balance, while regular physical activity helps promote the beneficial bacteria and maintain gut health. So, of course, the obesity, particularly abdominal obesity, increase the risk of the early onset by altering the gut microbiota and also inducing DNA damage, with the highest risk observed in the individual 20 until 29 years old with odds ratio 2.26. So the statistic also showed that the significant association between the smoking and with the early onset of the colorectal cancer. So how about the clinical presentations? The symptoms were longer than what durations, and both of the significantly longer in patient with young onset CRC, and young patient also had more advanced stage of the diagnosis. Usually common symptoms is the abdominal pain, lower of the hemoglobin level, rectal bleeding, diarrhea, and others. In addition, hematochezia and abdominal pain have been reported in the most common symptoms in young patients with colorectal cancer. And the diagnosis of the colorectal cancer in young adults is similar with older patients, but it often happens later because cancer is less suspected in young age, and the primary diagnosis methods in colorectal cancer include the, of course, non-invasive tests, guaiac-based fecal occult blood test, and also FIT, and invasive procedure like colonoscopy, and also CT colonography, and also flexible sigmoidoscopy. A guaiac-based test and also FIT usually used for the test, and recently globally the FIT is the most commonly used method for colorectal cancer screening because have a higher sensitivity. However, in the some lab in Indonesia, if we didn't mention about the FIT, usually most of them use the guaiac-based test. Colonoscopy, of course, we can make a classification and most effective for early and also reliable diagnostic. And about CTC is less invasive, but it is low risk methods for detecting. But about localizing colon polyps, cancer may miss small lesions and involves still bowel preparation, radiation, and also potential the follow-up test. I think flexible endoscopy can diagnose colorectal cancer and the polyp in the region, but since it doesn't see the entire large of intestine, the follow-up of the endoscopy need a problem. And these figures show that the microbial diversity was markedly increased in young onset of the colorectal cancer, if we against the old onset of the colorectal cancer. So this result suggests that young CRC group has unique diversity and microbial distance metric from the old CRC. How about the treatment approach? Standard treatment for colorectal cancer, of course, including surgery, chemotreatment, radiotherapy, and also targeted therapy, depending on the cancer stage and patient condition. And current anti-colorectal cancer drug that the specific target molecular pathway, including the anti-VEGF, vascular endothelial growth factor receptors, and also how to block the anti-CTLA4 and for the therapeutic target for dendritic cells. In patients under 45 with T1, colon or the rectal adenocarcinoma, both local excision and also radical resection provide high 10-year overall survival, with radical resection showing the slightly better outcomes. And the same results also show that the cancer-specific survival with slightly higher rates for radical resection. How about the surgical intervention on the primary tumor and also on the metastatic sites significantly improve the overall survival in the young metastatic colorectal cancer patients? And the graph shows that after 25 months, the younger patient had long better survival compared to the older patients. In the graph B, you can see that show the overall survival in young patients was slightly lower in the dead old patients over the short term, but then show an improving trend approximately 3 years. Of course, these slides show that the more young patients receive postoperative treatment compared the older patient because they have get the requirement of this. And however, the low response rate, about 12.8%, that palliative therapy achieved impressive 92% disease control in colorectal cancer patients, highlighting that its effectiveness in stabilizing the disease. And the median of overall survival, it was 33 months in patients with colorectal cancer that receiving palliative therapy, and the 1 year overall survival in the patient of the colorectal cancer was 63% and 67% in the rectal cancer. How about the patient who didn't receive radio treatment, had the worst outcome compared to the host? receive radiotherapy in any form. And radiotherapy in colorectal cancer is used to improve local tumor control, enhance surgical outcome, reduce recurrence, and also relieve the symptoms. How about the quality for the young CRC? Many studies show that the young adult of the CRC patient often has the lower quality of life due to the symptoms, stressors, emotional, physical than older patients. But why? It's happened because younger cancer patients experience greater financial and also career impacts rather than the older patients, including the higher risk of the work impairment, job loss, and also financial burden, and of course, psychosocial distress. And in addition, that the younger patients are often the middle growing of their careers and families. So cancer maybe can disrupt work and also financial responsibilities. Early onset of CRC patients also exhibited significantly lower psychological and emotional functional scores compared to the old group, and this largely due to the life state pressure, unexpected diagnosis, and also concern about the long-term of implications such as financial and career. The figure shows that young of the CRC showed better cancer-specific and overall survivor rather than patient age 50 and older, lasting to up to 10 years after diagnosis. So, of course, the prevention is the key. Colorectal cancer can be prevented by maintaining of healthy diet, avoiding the smoke, excessive alcohol, earlier screening, and know the symptoms. Know the symptoms and screening is crucial, I think, as many colorectal cancer are diagnosed in the advanced stage, and the strategies to prevent colorectal cancer by promoting a healthy lifestyle, initially early screening discussion, and documenting life family history. It also emphasized identifying high-risk individuals for timely referral to screening of genetic testing. Professional societies recommend that colorectal screening starting at age 45 until 50 using the guaiac-based fecal occult blood test with interval or based on the risk and test type, including also colonoscopy. And for individual with increased risk with colorectal cancer, screening colonoscopy is recommended every 3 until 10 years, depending on the personal and also family medical history. Of course, as the conclusion that the incidence of colorectal cancer in young adults under 50 years old have been rising globally over the past few decades, contrasting with the declining rates in older patients. And risk factor of CRC in young adult is genetic factors, lifestyle, and also environmental exposure. Hematostasia and abdominal pain reported is the most common in the young patient with CRC, and younger patient that significantly lower physical and emotional quality of life rather than older patients. Therefore, the increased awareness and education about CRC symptoms in young adults are crucial for earlier detection and also better outcome. Thank you very much.
Thank you, Professor, for that very nice summary. Well, to have time for some questions. Professor Mita, if you want to. Any questions at all from the audience?
So for me, let me ask the first question. Thank you, Miftah, for your great talks. Right now, in many of the ASEAN and Asian countries, we have more prevalence of the patients with early onsets of colorectal cancers. And as Andy talked yesterday, most of their guidelines, they led us to have screening colorectal cancers in the age of 50s. A new guidelines from American Society of Cancers, even 45. But anyhow, it's more and more cases of very early onset, even sometimes less than 30 years. So you have any clinical clues, any clinical or predictive factors you can screen, and let's have a chance to early detections and prompt treatment on specific kinds of these patients.
I think we have also concern that For example, in Indonesian case, the culture and the value, if you do not have habits for stool every day, they think it's not problem. If you feel dyspeptic symptoms, they say it is problem. But although most the patient in the young age now, because they change the food habits, many of my patients in the young age just take stool once a week, 2 times a week. It's not problem for them because the value not say it is problem. So why now in the our table we recommended mention about BSFS. BSFS put in the table and always ask how many times you have bowel habits. If your bowel habits less than 3 times a week and do not the target with BSFS 4, it is problem. So and also maybe now our government started this year because the association pushed a lot to make the screening of with the fecal occult blood test to do in the, but unfortunately not in the young age, focus not young in the age. But anyway, we successful to ask the government to do this screening to reduce the colorectal cancer in young age. Thank you.
If I could follow up with a question. You did a very nice summary discussing the different risk factors that have been uncovered for early onset. I'm curious to hear from your perspective in your country, do you feel that those risk factors are the predominant risk factors of the people you're seeing in your clinic, or do you feel there are some distinct ones in Indonesia?
One of our studies showed that different with other countries, Indonesia is started the colon cancer without inflammations. Most of them started maybe with a genetic or other factor. Maybe in this year I have the 2 publications with Professor Yamaoka about it, and we discuss about the difference of the risk factor of the colorectal cancer in Indonesia rather than the other country. Of course, because we don't have the data about the genetic influence link disease or something in our country, it is also become the questionable, still questionable, especially in the young age. Thank you.
Okay, thank you very much.
Thank you very much.
Next, we're going to have Professor Thawee Ratanachu-ek for the next talk. I believe that all of us here is no need for much introductions about Professor Thawee. To briefly, Professor Thawee is the pioneers, is the leaders and the founders of the GI Endoscopy Society in Thailand. I believe that all of us in Thailand think that Professor Thawee is a distinguished medical instructor for the GI endoscopist, nearly everyone in Thailand. Please, Professor Thawee.
Thank you very much, Professor Ratha-korn, for kind invitations. Deputy Speaker, all participants, good morning, everyone. I would like to express my gratitude to Professor Ratha-korn and Professor Varocha for having me this one. So this my talk is. I think this important slide. The patient brings the CT or OMR to you, and then report is one of the pancreatic cyst. So hopefully after my talks, you can get some small information and can explain to the patient what should the patient or the physician to do that to make sure of this particular situation. So my talk will have the menu, what we have in the box, how to approach, especially to manage the patient, and small things that can be developed at this moment in terms of the future perspective. So as you know, what in the box, as you know, it's a pancreatic cyst have the various pathology and different in terms of the nature of the cyst. And Some of the pancreatic cyst is inflammation and can compete with recovery or resorption. But some pre-malignant and turn to be the malignant in the future. Most we found in the incidental from the CT or MR, mostly in asymptomatic patient and small cyst. So even small cyst is major concern for the patient and also physician. So to make sure this cancer or not. Even very small percentage of the malignant, but still not 0%. And you can see right now we have several diagnostic modalities available, but some cases still difficult to get the accurate diagnosis. And also multi-society guideline available. Even these two couple of years from Tokyo guideline and also from the Hong Kong guidelines come up in the clinical practice. So what incident that we have, roughly is 2 to 14%, violence 8%. I think depend on the age of the patient. You can see it's more young down after 70-year-old, maybe it's up to 1/3 or 40% have pancreatic cyst in the costal imaging. And mostly very small cyst, less than 1.5 or 2 cm. More than 2 cm only is less than 1%. Also, already mentioned about the potential of the malignance. So you can see it's this cartoon is various type of the pancreatic cyst. So we can divide to two groups, the true cyst and secondary cyst. And more importantly, to separate between neopathic cyst and non-neopathic cyst, because non-neopathic cysts are mostly no malignant potential. So in the neopathic cyst, you can see the SCN is mostly non-malignant potential, and MCN, IPMN is more in terms of to focus on because of malignant potential and some value that you can see the spen and also the cystic lesion of the pancreatic. So I think in the clinical practice, most of guidelines emphasize on IPMN and MCN. I give you some 4-minute feature of the cyst that commonly seen on the clinical practice. Number one, the SCN is mostly is the non-malignant potential, and MCN and IPMN is mucinous cyst that are more malignant potentials. I think not only for the imaging, but the demographics of the patient also important. You can see MCN mostly is a female, so more than 95%, and location mostly on the body and tail. And you can see the morphology of the scan. It's more clearly if you see a MR compared with the CT, and some CT can show you classification, importantly like a central scar in case of the SCN more typically. And of course, from MRI, you can see connection with the band duct of the MPD, that you can see that IPMN. So not only for the pancreatic cyst need to be emphasized. So pancreatic parenchyma also very important. You need to look at, not miss it. You see from many studies from Japan, even you follow up for the long term, allow 1.2 the list of the PNET, and allows to verify same. You can see concomitant pancreatic parenchymal cancer as well on the cyst. So how to approach, emphasize in terms of the get diagnosis. If you get more accurate diagnosis, I think it's more proper select how to take care of your patient. Of course, you can see CT scan or MRCP or MRI first, but in some imaging can give you the idea in terms of the confidence. For example, in case of the cyst unilocular, history of the pancreatitis, or you can follow up by imaging the cyst speaker short period of time. I think this is very high confidence to get this the pseudocyst, not the true cyst. Or in CT that you can see that the central scar in the female. I think mostly the SN. But not surprisingly, It's not uncommon in Thailand. Sometimes we can find this particular situation, but not female, but in the male patient. But in this particular case, not ASEAN. So that means in male patient, even the central scars, be careful. This not ASEAN. We call this maybe it's a low. You need more get the confirmed diagnosis. In MCN, it's mostly present with unilocular female. Of course, this the commonly seen, but mostly lesion on the body and tail pancreas. If you find unilocular at the head of pancreas, this might be not MCN. So of course, mostly if you see MRCP with the duct connection, we can conclude this with a high confidence this IPMN. You can see from the CAT scan, some case you can get really high confidence for analysis. Some is very low confidence. What you do? So I think in case of the low confidence, maybe you require more investigation. So this is the first summary. If you give information to your patient, if you're more confident in terms of the IPMN or MCN, it's a more lesion less than 2 cm or 1.5 cm or even 1 cm. Mostly you can not find any malignant fissure. In this case, you can surveillance. But it's a typical high confidence in female central scar on the CT. Mostly it's ASEAN. You may be just follow up just short period of time, 6 months. If stable, may require to follow up. But in group of the low confidence and maybe look for the malignant feature, it's really important. Maybe endoscopic ultrasound is one option for you. Of course, if she can have the definite in terms of the malignant feature, solid component, symptomatic, in this group maybe require surgical intervention. So endoscopic ultrasound give you more proximity of the lesion that you can see more clearly in terms of the morphology of the patient. If you look at guidelines from the 4 different society, most of guidelines emphasize in terms of to figure out of the malignant potential, because this is one of the key improve the survival. But other side of the endoscopic ultrasound are not only to see the malignant potential, but also to get the accurate analysis. As already mentioned about is low confidence, you need to get more in terms of analysis. What we can see on the endoscopic ultrasound, of course, number one, the cyst morphology. You can see MPD, PD connection, and even concomitant parenchymal abnormality that you can see, nearby structure, and other thing that you can see from the endoscopic ultrasound. So if you look at the morphology from the endoscopic ultrasound, you can see like a microcystic or macrocystic. It's mostly the competitor with the SCN. But some small number of the case, it look like the solid tumor that there's a violation of the SCN. This one of lesion that difficult to get answered. Mostly we require the needle. So in case of IPM, already mentioned about mostly the shape morphology is like the grape, the shape, and also MCN mostly unilocular. CAT scan you can see maybe the eggshell calcification, or in case of malignant potential, maybe you can see inside in terms of the peptic growth or myelonodule. And more difficult, you can see on the red color. There's maybe one unilocular, small micro cystic lesion. It's really difficult because of this the group of the patient. You can see this overlap mapping of the morphology, especially SCN. SCN can present with unilocular. If the typical honeycomb is okay, that's good one. It's not typical one, maybe unilocular or some last one cystic cyst and small one. This make it very, very difficult to get the answer even from the imaging. What we have, if your imaging is not confirmed or really low confidence, so we require additional modality to get more. Right now, in the clinical, mostly we have the 4 different techniques. The number one is a contact agent. Number 2, more commonly, is with the needle. FNA. The third one is I think is more and more in the major center is through the needle biopsy, the forceps. And the last one is more expensive one, intracytic cell inside we call the with the cervical. So what we have if available in your country with the contrast, what contrast provide the number one, the vascularization of the inside the lesion, especially for endospersa. It's not just a mucin or mononodules. If you inject the contrast, you can see some small micro bubble or to show that the microvascularization inside that maybe is the true nodule, not the mucin part. Or you can see more clearly the vascularization of the septum or thickness of septum. That a good benefit. Additional your information before you start to decide to M&A or not. The second one is a needle. I think it's a needle is more commonly used in the clinical practice. But just remind you, if you decided to pick your needle up, so you need to make sure that your needle, you change your management. Otherwise, you lose money, you burn your money, and so you get some the complication. So maybe infection, small number of the pancreatitis, or even very small percentage of the dissemination. This is the first report from Japan in IPMN case. So if you decided to put the needle in, of course, right now, even less data at the moment, so we still practice give the antibiotic, and we just only the single shot to put the needle in, depend on the size that you use, 22G or 19K needle. We use FNA needle, not FNB needle, and you try to aspirate as much as possible. So if you get the tissue, if you get the fluid, what to look at? The number one, the color, viscosity. You can send biochemistry, and if the mucin, what happened if we show you later on, and in the future, if we give you some small slide in the last is molecular analysis into the biomarker. So number one is important. If you aspiration, you can see the color and viscosity. I think these are two prominent features. You can see on this slide, cirrhosis mostly is depend on the case. In traumatic patient, mostly is colorless because of only the pancreatic fluid. In case of cirrhosis, mostly you can get the deep bowel or some but for ASEAN, mostly we get the store color, but in some solid or dimension solid type of the ASEAN, mostly you get the blood inside. MCN mostly is clear and very thick fluid. If you use a 22G needle and you aspirate with the suction, and you cannot see small fluid come out, mostly that MCN. So recommend to use a high power suction, so maybe 30-40 with suction. In case of the IPMN, mostly is colorless. And some case of even the MCN, sometimes the patient have the pain, like bleeding. In that particular situation, maybe you can find some more brown the fluid. So in my center, sometimes we found some like the fluid inside the cyst. And the patient immunocompromised, be careful. My center, we found some case of the tuberculosis when you aspirate, and you can see the pus, and you can see the FMB positive in this particular case. And then what you send for the biochemistry, the number one is CA. I think CA is quite common to see. Number one on my list. You can see the CA high in case of the cystic is MCN or IPMN. And also the my list high in case of the connection IPMN or peptic cirrhosis. I think it's the most to signal that you send. Right now, it's more commonly to use a bedside to test with the glucose stick. we cut off around 50 milligram per deciliter. If the really low one is mostly is the mucinous lesion. You can see on this meta-analysis to show you this really good screening test to difference between the mucinous and non-mucinous with a very good diagnostic accuracy up to 94%. And this case, you can see my case is a 1.8 cyst at the body. And this really allow nearly 50-year-old and unilocular at the body. In Thailand, in contrast, be not available. I'm not sure this is the mucin or this the mirror nodule. So decided to put the needle in. You can see when you put the needle in, this case we put the 19-gauge needle and we apply suction. So all the suspected nodule is not the nodule, that's the mucin pack, or the mucin come into the needle. This is one of the advantage that we have. As already mentioned about more center, especially center that have the therapeutic intervention in terms of the cyst ablation. I think through the needle scope biopsy is more worldwide to use it. You can see the pool diagnostic accuracy is 70, SPT is not bad. I think it's up to 80-85%. This is one of the options to get more in terms of pathology, not the cell that you send for the cyto. And of course, this is a more expensive one. You can see the meta-analysis is quite good. This needle-based confocal laser endomicroscopy or CBCO. You can see not spicy, this diagnostic yield is really nice, really high. But still really limited. I think this modality we can only see mostly in the light demo. But in the clinical practice, I this not, because of the number one really expensive one and not available. But if you have the machine, this is a very good one to additional, especially you use a 19-gauge needle. And not only the morphology, you need look at the malignant point here as well in terms of the volume feature, highlight feature, and also already emphasized in the concomitant, the pancreatic cancer. How to find concomitant pancreatic cancer? Normally, this particular case is a very small one. So need to see the MPD. If you find the location that different in terms of the caliber of the MPD, and that area you need to emphasize, this might be the small, the pancreatic adenocarcinoma. And then if you get more information from additional modality, I think it's more happy to get the accurate analysis, and you can plan which one should be surveillance, which one should be sent for the surgery. So how to manage it? I think that come back to summarize the number one. The number two is if you get confident diagnosis of MCN impairment but no volume feature, you can make a surveillance. I will give you more in terms of the timing. And if the case back to be MCN, maybe just short period of time to follow up or non follow up, and use some more multi volume feature or high risk feature for malignant. This schedule this patient and send the patient for surgery. You can see we have multi societies guideline, and already mentioned about the new guideline from Kyoto and also from Hong Kong. So in terms of the timing to follow up, this gives you the general idea, the guideline, depend on the size. If the size less than 1 or 1.5 cm, you may be follow up with the MRI. I think the MRI gives you more information compared with the CT. If 2 to 3 cm, maybe the first one may be follow up with 6 months and then yearly. And if more in terms of the bigger one is more than cm, this is the more risk of the cancer. So the timing of the growth rate also important when you follow up, because of the growth rate when you follow up is more than 2.5 cm. That means more turn to be the malignant. I think that's give you just general idea how to surveillance the patient in terms of the timing. And if you more to see the MCN, in MCN also there's some different guidelines cut off into the 3 cm or 4 cm if no any the malignant or high risk feature. So I think this is still debatable. And recently is the international evidence-based from Tokyo guideline. I think in Japan, they more emphasize on IPMN because of a lot of patients. And I think even Asia or Thailand, the number of IPMN right now increasing. So if you see in IPMN, you can see more high risk and more worrisome feature, maybe send this patient for surgery. If no, you may be surveillance depend on the size. So if more than 3 cm, right now we follow up every 6 months. Less than 2 cm, maybe yearly. So 2 to 3 cm is in between, so alternate between MR or US. So this the summarize how you get the general information from the different guidelines and keep information for your patient. So what small new modality that more emphasize. Number one is AI. I think for the near future, mostly emphasize on how to get the early diagnosis of the cancer. I think this good study from Japan in ASG Cancer Center. So they create the MR US guided the AI. And this is the first dependent study. You can see in case especially IPMN seban đặc Thai to different between malignant and benign. You can see the MR give you more confidence compared with the human eye. And the second one is fluid, especially for the molecular the biomarker. I think some more study in US. And maybe give you more information about this particular cyst. So if you look at a lot of the different molecular marker, so you can see more in terms of get the advanced new patient insight. In different the guideline also is you can see the difference in terms of the detection allow 50 to 75%. I think need more information for this and still far away in clinical practice. So ladies and gentlemen, as I give you just an overview of the practice that you get the CT and you can explain your patient how to do that and how to follow up the patient. Thank you very much.
Thank you very much, Professor Thawee, for your very excellent talk. So have any questions on the floor? I got questions from the online. So sometimes we got struck with the pancreatic cyst for the management. How can we best differentiate mucinous such as IPMN or MCNs with non-mucinous cystic lesion when imaging features are overlaps?
So many that means imaging overlap mean after endoscopic ultrasound, right? So already mentioned about this imaging overlaps is that mean really low confidence. In this particular situation, depend on the modality that you have. It when they start with the contrast, but in Thailand normally we start with the needle and get more information. But some case, especially right now in my center, we prefer biopsy in unilocular cyst, get more information compared with the cyst fluid analysis.
Brief questions, please.
Thank you, Professor Thawee. One dilemma that sometimes we face is the elevated CA19-9. Only European guidelines advocate the use of CA19-9, and we do encounter the elevated level. But EUS and imaging does not really suggest any high-risk features. Would you consider FNA in those cases?
So I think also a good question. Normally, it's the only one society recommend to follow up with CA19-9. In different flow guidelines are not mentioned. So things in the pancreatic cyst mostly CA19 will going up with friendly cancer. That means why follow up CA19 because of as already mentioned about the concomitant pancreatic cancer. But in concomitant pet cancer, CA data is high up. So things maybe some benefit. But if you emphasize on the pancreatic cyst, CA data is not any information. Thank you very much.
So our final speaker of the session will be Professor Kentaro Sugano. He is a professor emeritus at Jaichi Medical University in Japan and one of the world's experts in acid-related disorders. And he will be speaking today about beyond PPIs, what's next in the evolving management of GERD and peptic ulcer disease.
Good morning, everybody, and good friends. Thank you very much for inviting me, Varocha, and also Ratha-korn. And unfortunately, my time, only 5 minutes left during this session. So please allow me to speak a little bit more. And on top of that, Ratha-korn asked me 2 topics. One is GERD. The other is peptic ulcer disease. So that means only 10 minutes for each. Nevertheless, I have 40 more slides. So I hope I can finish in time, but 3 minutes left. So first I'll touch upon the GERD. These days after Lyon consensus, updated probably a couple of years ago, they discriminated PPI refractory type of GERD into 2, refractory reflux-like symptoms, and second, refractory gastroesophageal disease. The latter is the real disease. The former is a bit confused. I think a lot of conditions are mixed up within this category. For example, if you use PPI is now the best way to control GERD, they actually can't handle everybody. For example, symptomatic resolution only achieved about 70%. So that means 1/3 of the patients are complaining about their discomfort, continuously having their troublesome symptoms. So for the moment, we don't have a greater way to manage those difficult persons. And the reason why it is not enough to control their symptoms. Before you consider another way of handling this type of patients, you have to think about diagnosis of GERD is correct. Second, the GERD symptoms related to real reflux. And the third, then the acid suppression adequate. Those questions should be considered. And indeed, if you ask patient if you have a heartburn or epigastric discomfort or pain, burning sensation, patient actually can't, understand what doctors are saying. For example, as you can see here, even doctors, general practitioners, can't correctly explain epigastric burning versus heartburn. Heartburn is a retrosternal position, usually having the upward movement, whereas epigastric burning is this epigastric region, pain or burning sensation. The patient really can't understand their symptoms belong to either heartburn or epigastric burning. That causes a lot of problems for the diagnosis. So you have to consider, and this pictogram was developed by Jan Tak, my friend, And if you show this type of pictures, we call pictogram, then patient must have a better understanding what their symptoms belong or close to this pictogram. So you may use this kind of pictogram when you ask the patient's symptoms. I told the young Tuck to sell this pictogram, but he never did anyway. And also the second problem is that often the case that patients have overlap of both functional dyspepsia and GERD. Just like you can see, both PDS type and EPS type have acid reflux overlap with their functional dyspeptic symptoms. And part of them, if they have acid reflux, can respond PPI. But not many of them have acid reflux, as you can see on the right side of the slides. And indeed, if you have functional dyspepsia, either type EPS or PDS, PPI failed to show any superiority over placebo. So if the patient has both functional dyspepsia and GERD overlap, if the symptoms won't improve, that means patients still complaining their symptoms. And also, if the patient has NERD, they have a lower response rate. And because of the about 50% of the patient have functional heartburn, which is not related to reflux at all. And even if they have a reflux, many of them are non-acidic, as you can see on the right pie chart. And also, you have to consider about the different etiologies of their symptoms: esophageal motor dysfunction, functional heartburn, Zinker's diverticulum, esophageal web, eosinophilic esophagitis, etc. So in those diagnoses, you need to do high-resolution manometry, or you do endoscopic biopsies to correctly diagnose these non-GERD esophageal pathologies. Okay? And this is a summary of the putative etiologies of PPI refractory GERD. And all the black bracket has nothing to do with the acid reflux. So PPI have no role, actually. Only impaired mucosal repair as inadequate acid control, then there is a role for the acid suppressant. And indeed, this sort of management strategies are based on the Lion version 2. And now Los Angeles grade A esophagitis is not the concrete evidence or solid evidence for GERD, because of many patients have no symptoms at all. So in that case, you need to have the acid exposure time measurement, etc., to judge that really belong to the solid, valid GERD disease. On the right side of the panel, if you have your patient have Los Angeles B or above, then without doing any impedance or pH manometry, you can judge the patient have solid GERD. And then in that case, optimize PPI to control symptoms, or aggressive lifestyle medication or cognitive behavioral therapies are recommended. And several options when you do PPI therapy. lifestyle modification already done, and relaxation training, diaphragmatic breathing is effective, and switching PPI or asking patients if they take PPI correctly, especially in the breakfast, before breakfast, that is important. And today's main topic is switch to PCAB. Now the PCABs in the center stage. Yesterday, I think Professor Somchai, Lila Sorbonne, did a great lecture. Have you heard his lecture? And tomorrow, they also have some lectures on GERD, but PCAB has more potent acid suppressing effect, and I mostly spend my time for these agents. Now, there are several PCABs. The first one put into the market was revaprazone, but this was withdrawn in Korea. I don't know, they are exported to China, but I'm not sure if this revaprazone is available or not. And then comes vonoprazan, which is a Japanese product, and now you have a vonoprazan here in Thailand too. And the tegoprazan, so-called Cape Prazan, was initially, I think, created in venture business in Japan, but compared to vonoprazan, the potency is a little bit weak. So they actually sold the license to the Korean company. And the Korean company developed clinical studies, and they have been approved in Korea, and maybe here in Thailand too, right? And then linaprazan was initially developed by Astra, but Astra stopped development because of it was equipotent with esomeprazole, and they also had some liver damage. So that's why they withdrawn this development. But another small company took the license from Astra, and they have developed linaprazan. I think it's precursor form, and now approved in China. And the keverprazan was developed in China and now approved in China. And the fexoprazan is again developed in Korea, and also the zastaprazan recently approved in Korea. I talked about the data a bit later. And of course, vonoprazan is the most successful PCABs developed in Japan, and especially for Los Angeles grade C and D, it has a superiority over lansoprazole. And for maintenance of GERD, it was also superior to lansoprazole, as you can see here. And for 5-year safety trials, as you can see here, vonoprazan is superior and safe for at least 5 years. And this is an Asian, I think, clinical trials, and I'm not sure the Thailand is involved in this trial, but China, Taiwan, Korea, Singapore, Malaysia group actually did this job, and also similar findings was reported. And in the USA, which is a great market, recently approved the vonoprazan for esophagitis. As you can see, it is superior to the lansoprazole, especially for LA grade C and D. However, the NERD. In Japan, unfortunately, lansoprazole, there is no superiority of vonoprazan over placebo, as you can see here. Even a little bit, symptom resolution is earlier than placebo, but nevertheless, it's not significant. However, in the USA, vonoprazan showed some superiority over placebo, as you can see here. And then if you switch it to the placebo, then it comes up to the placebo level. That means some significant, I think, improvement of heartburn symptoms in the Western population. How about other tegoplasm? It seems similar to the esomeprazole, and kevaplasm showed similar result, no superiority. And this is a linaprazan glutarate, which is the precursor form of linaprazan, shows similar result, but a little bit better than this case is lansoprazole, and earlier achievement of higher rate of healing. But for Los Angeles grade A and B, it is similar. So this is a summary of the, especially for grade C and D esophagitis, PCABs has superiority. And this is a newer one, which was not involved in that meta-analysis. Fexaplazan is similar to the esomeprazole. But this last one, zastaplazan, very recently introduced into the market, shows superiority of LA grade C and D, especially high healing rate, 100%, you can see, and over esomeprazole. So the zastaplazan seems to be very potent and long half-life, and also probably the efficacy of the 24-hour pH monitoring showed the similar result with vonoprazan. So this compound may be the future rival of vonoprazan, I think. But PCABs are not, perfect drug. As you can see, this patient continued to have the PPI, PCABs for maybe 10 years, and then they developed GNET, multiple GNET actually. And then, because of the development of GNET, they switched it to the H2 receptor antagonist. It stopped it, but still it regressed. But as you can see, the severe grade of GERD developed. So what we should do? And after all the GNET endoscopically removed, what to do? So you can't use PCABs or PPI because of the development of GNET. They chose to do endoscopic anti-reflux therapy. Okay. And as you can see here, the first one, so-called ARMS, anti-reflex mucosectomy, developed by Inoue. Dr. Inoue shows the nice result. As you can see, after ARMS therapy, the Mesta scores regressed very much. Heartburn score is decreased, regurgitation decreased, very effective. Now they developed more sophisticated anti-reflux mucosectomy with valve formation, so-called ARMS PV. And this is actually, the ARMS therapy is insurance covered now in Japan. So people are using if a patient developed refractory GERD symptoms or refractory to the PCABs therapy. And also, they also developed a much easier method because technically a little bit difficult to do the ARMS therapy. So they call AMA, anti-reflex mucosal ablation. They use radiofrequency ablation to do the similar, to have the similar result. And ARMS and AMA for GERD show the about 80% of success rate, as this meta-analysis shows. So you can use endoscopic therapy for refractory GERD too, if you can't handle the patient's symptoms or GERD by PCABs. And now I move to the peptic ulcer disease. And as you can see here, vonoprazan and traditional PPI shows a similar result, and meta-analysis also shows the same. So there is no change because the requirement, the pH control for peptic ulcer disease is pH 3, which is much lower than the pH 4 required for GERD therapy. So to heal peptic ulcer disease, you don't have to have a very strong, potent acid suppression. But nevertheless, if the patient have NSAID, continuously using NSAID, you need a more potent acid suppression because PPI only heal less than 80%. And also another category recently, I think, pointed out by Hong Kong's group, Francis already left, but he actually pointed out this idiopathic, non-HP, non-NSAID ulcer, difficult to heal and also very easy to develop complications. So this idiopathic peptic ulcer is a major problem now. And as you can see, this is an NSAID ulcer, which is resistant to PPI. But if you continue PCABs, they eventually heal. The healing process is delayed. But if you use vonoprazan for a longer period of time, for example, in this case, 6 months, they completely achieve the healing. And this is our study, actually. The prevention, once NSAID ulcer is healed, then you need to prevent recurrence. And PCABs is very good to control recurrence, as you can see here. And also the PCABs is superior to PPI to control the idiopathic peptic ulcer disease, as you can see. And sometimes it's difficult to completely heal, achieve the healing of these type of idiopathic peptic ulcers. In that case, for this case, additional drug, trimethoprim malate, which control the muscle contraction, if you add it to these difficult peptic ulcer diseases, they can achieve. This is a sporadic case report, but nice healing was achieved. Another case is this one, and they added misoprostol in addition to vonoprazan. It was very difficult to heal, but eventually they achieved healing after combination therapy. So this is a summary, and PCABs offer benefit over PPI-resistant GERD, and then benefit of PCABs will depend upon the drug types. So there are many PCABs, weak one, rabeprazan, which was withdrawn already, and also the very potent one like vonoprazan and zastaplazan. And in between, there are several PCABs with equivalent potency with esomeprazole. And prolonged use of PCAB and PPI can cause GNET, so-called carcinoid tumors. And in recent years, I think if you continue to use PPI or PCABs more than 10 years, several reports have been emerged to show the development of GNET. So be careful after prolonged use of PCABs or PPI. And in that case, you can switch to the endoscopic therapy. And for peptic ulcer disease, PCABs may be more effective than PPI for healing NSAID ulcer or idiopathic peptic ulcer. And PCAB-resistant peptic ulcer disease still exists, and in that case, you can probably combine additional medications such as misoprostol, etc. Thank you very much. This will conclude my talk.
Thank you for that excellent talk. Unfortunately, we don't have any more time for questions. So if you have any questions, feel free to approach Professor Sugano after the talk. So thank you for a wonderful session, and we'll move on to the next session.
Thank you very much to our speaker and moderator for the excellent session.